Conflicts. So I'm here to talk to you about supervised exercise therapy, what, when, and how, and it would be really remiss for me not to take a moment to thank a close friend and colleague, Alan Hirsch, who passed away actually 1 year ago right now, who never got to actually see that CMS decided to fund supervised exercise therapy, something he worked on for his entire career. So this talk is in memory of Alan. So I view this as life having choices, and the choices aren't always mutually exclusive, and I think that's the message here. I think the message is it's not just whether you should offer supervised exercise therapy instead of something else. So what do I mean by this? Well, for example, you're flying on an airplane, and you choose to fasten your seatbelt or not. If you need to put a mask, an oxygen mask on, you choose to do it or not. I mean, these are just silly things. Well, it's the same kind of concept. And when you care for patients with claudication, you only have one goal, right? You believe that whatever you offer them is going to make them feel better, walk faster and farther, and get back to their normal life. So when you see this in a patient who presents with hip discomfort with walking, you immediately have to decide whether you're going to do this or you're going to do this, because I don't think anybody would offer surgery for this anymore. Well, there are guidelines and there are position statements that discuss what therapeutic strategies are available. And on this one Circ research paper, which is a great review, if you look on the symptomatic side, everything starts off with medical therapy and risk factor intervention, which Josh is going to talk about momentarily, strategies to reduce the risk of limb loss, which in that particular case would be very low, and then how do you improve their symptoms? We all understand that basically these are narrowed pathways, but it goes way farther than just a clogged pipe resulting in the inability of patients to walk. And so where would exercise play a role? Well, it turns out that it's much more than what we generally tell our patients, which is this can stimulate collateral pathways, right? That's what you tell your patients. New routes of blood that go around the area of narrowing. But there's a lot that we now know about impact on mitochondrial dysfunction, oxygen hemoglobin dissociation curves, induction of angiogenesis, et cetera. And these metabolic and mitochondrial abnormalities are really at the core of why patients become deconditioned and can't walk. So you can reassure your patients that not only is this helping their ability to walk, but it's actually going to help their ability to live longer. So what about exercise therapy? Well, there's a ton of literature out there. This is the older literature. This was a Cochrane review of 22 randomized controlled trials. And just with supervised exercise therapy alone, you increase maximal walking time, pain-free, and maximal walking distance to great degrees, clinically meaningful degrees. And so the guidelines actually went as far as to tell you what the prescription for supervised exercise therapy should be. So those prescriptions include things like happening 3 times a week for anywhere from 30 to 60 minutes at a time. Patients should walk to maximal discomfort and stop and stand, not when they first start to feel discomfort. They should walk at a pace that brings on the discomfort sooner. So the more aggressively you are in a supervised exercise program, the faster patients will see clinical benefit. This should continue for at least 12 weeks. And in association with this, don't miss the opportunity to talk about cholesterol and diabetes and cigarette smoking and all of that stuff. So as a result of all of this data and really decades of lobbying Medicare decided that it was worthwhile now to fund supervised exercise therapy. And in fact, there's now not only a reimbursement code, but reimbursement for this. So why not then just offer exercise as the sole initial treatment for claudication? Well, I think this is the real reason. A, patients really don't like doing this. When they feel discomfort, for any reason, they want the discomfort to go away. Supervised exercise therapy is not a quick fix. It takes time. And so if your patient's not motivated, this just is not going to work. And secondly, they want to make you feel better. So they'll tell you that they're going to walk and things just aren't getting better when in fact they're just standing on the front porch for 30 minutes. So does this work? Well, it works. It just doesn't work quickly. So if you tell patients, hey, do this every day or 3 times a week, in 3 months you're going to notice a dramatic improvement, you're guaranteed that they're going to come back disappointed. or go someplace else. So 6 months is kind of the window. And by the way, it doesn't help everyone. So if you were really going to consider designing a therapy, you'd probably do it for people who have infrainguinal disease as opposed to suprainguinal disease. But nonetheless, it does help. And by the way, it's way more effective than unsupervised exercise therapy. So if you do this at home, it's way more effective. Trying to go backwards. Maybe I can't go backwards. There we go. So what data do we have? Well, I know Josh is going to go over CLEVER and ERASE in a much greater detail than me, so I just want to show you that Cochrane review was old data, initial data. The more modern data shows you comparisons of endovascular therapy to exercise. This is the CLEVER study, the NIH trial, and in this study, which looked at aortoiliac disease and claudication, supervised exercise improved peak walking time more effectively than optimal medical therapy. But at 18 months, the benefits were lost. The ERASE trial actually compared the combination of supervised exercise and endovascular therapy than exercise alone. Back to my opening comments, it's not one versus another. And in this series, it looked like the combination therapy was way more effective. Now, why didn't we show that in CLEVER? Because we couldn't enroll that fourth arm of the trial. The enrollment rate was so slow that we basically lost funding and had to end the trial where we did. The guidelines actually support revascularization and/or guidelines-based medical therapy. And so it's clear to me that supervised exercise therapy is first-line treatment for claudication, but for that osteal common iliac artery stenosis, I would think that the best therapy would be fix that lesion percutaneously and then enroll the patient in a supervised exercise program. Thanks very much.